Good morning, good afternoon, good evening. I hope you had a great weekend or week. Just that greeting hopefully covers all the bases here for whenever you're listening to this lecture. But throughout this lecture, I'll be going over the most crucial anatomy of the lower body, as well as some of the most common pathologies that you most likely see as a professional working with athletic populations. I certainly do not expect that you are all going to be experts by the time you are done with this lecture, but at least you will have a better understanding of what is out there and what you might experience with your athletes and your patients. So without further ado, let's get into the etiology and pathology of lower body extremities. Okay, so the foot and toes are made up of 26 irregularly shaped bones. They're all connected with a series of ligaments. The tarsal bones help to form the ankle and include the talus and calcaneus, and also include the navicular cuboid and three cuneiform bones that form the instep of the foot. The metatarsals are those long bones that lead from the ankle and the instep to the toes. And then the toes are just made up of the phalangeal bones. Just some anatomy review for you guys. An intricate network of ligaments and fascia within the foot. These ligaments and fascia structure the arches of the foot, and these arches assist the foot in supporting the body weight and to help absorb the shock when moving. The four arches of the the four arches of the foot are the medial longitudinal, the lateral longitudinal, the transverse, and the metatarsal arches. The metatarsal arch is shaped by the distal heads of the metatarsals and stretches from the first to the fifth metatarsal. The transverse arch extends across the cuboid and the intermediate cuneiform and forms a half dome. The medial longitudinal arch originates along the medial border of the calcaneus and extends forward to the distal head of that first metatarsal. And that's the main supporting ligament of the medial longitudinal arch, is that plantar calcaneal navicular ligament, which is also known as the spring ligament. So it adds that spring to the foot. It acts as a spring by returning that arch to its normal position after it's been stretched by some sort of compressive force. Okay, so it's springy. Lastly is the lateral longitudinal arch, which is on the lateral aspect of the foot and allows the same pattern as that medial longitudinal arch. And that lateral longitudinal arch is formed by the calcaneus, cuboid, and the fifth metatarsal. We also need to mention the plantar fascia and plantar aponeuroses here. This is a thick band of fibrous tissue that originates from the medial aspect of the calcaneus and ends at that distal heads of the metatarsals. It is a distal continuation of fascia that runs posteriorly from the muscles of the thigh to the muscles of the calf and continues under the calcaneus, where it thickens and becomes the plantar fascia, which I'm sure all of you have heard about. It lies very superficial between the skin and the first layer of muscles within that foot. It's important to understand these because when one is injured, they typically result in compensation within other parts of the arches and of the foot. And that can cause a lot of extra discomfort to the patient. It's also important to understand that having tight musculature in the thighs and calves can lead to disruption to the function of the plantar fascia, which can also cause injury. Muscles that cross the ankle joint into the foot, which we will cover a little later in this lecture, but here we are going to just focus on what are known as the intrinsic muscles of the foot. So intrinsic, that's just going to mean that the muscles originate and insert all within the foot itself, okay, without crossing any ankle joint. In general, these intrinsic muscles of the foot really only deal with the actions of the toes, but they also play a role in shock absorption and proprioceptive and balance control. So they're going to deal with that shock, proprioception, and balance, but they're also going to deal with toe flexion and extension, abduction, and adduction. The ankle joint is essentially formed by four bones that come together. There are the two bones of the foot in the talus and the calcaneus, and there are two bones of the lower leg in the tibia and the fibula. The tibia and fibula come down to meet the foot and form a bracket shape for the talus to fit nicely into, And that bracket is what creates the ankle joint itself, and it's known as the ankle mortise. So it is also important that you remember that the tibia forms the medial side of the ankle, and that bony bump on the medial side of the ankle is the medial malleolus, and that bony bump on the lateral side of the ankle is the lateral malleolus, which is formed by the fibula. These are important bony landmarks that you'll definitely need to know for when you are looking to determine if an athlete has an ankle or a lower leg injury, specifically when we're dealing with ankle fractures and dislocations and sprains. The ankle joint is also really made up of two joints. So we have the talocrural joint, which is composed of the tibia, fibula, and talus, so the ankle mortise. The talocrural joint allows for plantar flexion and dorsiflexion of the ankle, and the talocrural joint is really what most people refer to as the ankle joint. And then we also have the subtalar joint, which is composed of the calcaneus and talus, and the subtalar joint allows for inversion and eversion of the ankle. The tibia and fibula are held together by the interosseous membrane, and that's going to span the entire length of the shin. The anterior and posterior tibiofibular ligaments bridge that tibia and fibula, and they form the distal portion of this interosseous membrane. The medial side of that ankle is relatively stable because of a thick series of ligaments, and those ligaments are collectively known as the deltoid ligaments. This strong deltoid ligament, or collection of ligaments in the deltoid ligaments, in combination with the ankle mortise, specifically that lateral malleolus of that fibula extending past that medial malleolus, that's going to limit the ability of that ankle to evert. Okay, so eversion ankle sprains are much less common than inversion ankle sprains because there is a more limited eversion of the foot compared to inversion. On that lateral side of the ankle, we have three important ligaments. We have that anterior talofibular ligament, or ATFL, and the posterior talofibular ligament, PTFL, and then the calcaneofibular ligament, which is commonly referred to as the CFL, or CF ligament. And collectively, these lateral ligaments are much more susceptible to injury. So the contraction of the muscles of the lower legs produce movements at the ankle joint, but because several muscles extend beyond the ankle and into the foot and toes, they are also going to cause movements in the toes and in the foot. Several of those muscles will. What's important to understand about the muscles of the lower leg is that our body organizes them into different compartments of muscles, and each of these compartments is surrounded by a thick layer of fascia or connective tissue to keep them separate. And there's, again, four different compartments, and the first is the anterior compartment, and those muscles produce dorsiflexion. We have the superficial posterior compartment, and those muscles produce ankle plantar flexion. The lateral compartment is going to, the muscles within the lateral compartment are going to produce ankle eversion, and the muscles within the final compartment, which is the deep posterior compartment, those muscles are going to cause inversion of the ankle. So it's important to understand this about the lower leg, because there is a very specific injury called compartment syndrome, which we will discuss in a little while here. But that is created because of these compartments in the lower leg. Okay, moving on up to the knee. The knee is made up essentially of three bones. We have the tibia, which we just discussed for the lower leg. Then we have the femur and the patella. Within the knee, we also need to mention the existence and importance of the menisci, meniscus. These are two C-shaped areas of thick cartilage, and they really exist to help create a better fit between the tibia and the femur, as well as to help with shock absorption, fluid production, proprioception in and around the knee. These menisci are going to rest on that tibial plateau, and they are essentially there for proper functioning of the knee and promotion of knee health. The knee is held together by a series of ligaments, as I'm sure you could have guessed. We have the medial collateral ligament, or MCL, and that is there to help prevent the knee from forces that impact that lateral side of the knee. We have the lateral collateral ligament, or LCL, and that is going to prevent injury or help prevent injury from forces that impact that medial side or inside of the knee. The anterior cruciate ligament, or ACL, which I'm sure you guys have heard about, is there to help prevent that femur from sliding forward on that tibia. And the posterior cruciate ligament, which is the PCL, and that's there to help prevent the femur from sliding backward on the tibia. I also want to mention the patella tendon here. If you've been in other classes with me, you've probably heard me rant about this, but you know that I disagree about the name patellar tendon. Tendons attach muscle to bone, and the patellar tendon actually attaches bone to bone, right? So it attaches that patella to the tibia. So it should really be called a patellar ligament, but I won't go off on another tangent on that. If you've already had me in class, you've heard me go off about that enough. So the patellar tendon is there to help keep that patella in place in its groove, and also prevents it from riding too high or too low on that knee. The thigh, hip, groin, and pelvis really comes down to the bones of the upper leg, the femur, and its articulation with the pelvis. The pelvis is really the combination of three different bones. So we have the ilium, which is what most people call our hip bones, and then the pubis, which lies at the bottom and front of the pelvis, and the ischium, which creates the lower posterior third of that pelvic girdle. We also should include the sacrum here, as it offers a large area for muscles to attach to and acts as an attachment site for the two sides of the pelvis at the posterior part of the hips. But I want to be clear, though, that is not technically part of the pelvic girdle or part of the pelvis. It is part of the spine, okay? The other thing that I need to mention is that acetabulum. Okay, so that is where all three bones of the pelvis meet, and where the femur attaches into our hips. Okay, so it's our hip socket is more common name for that acetabulum. And the femur is supported here by a series of very strong ligaments, as well as that acetabular labrum. Ligaments of the hip that I'd really like to mention are those that hold the femur into that acetabular labrum. Much like the meniscus of the knee, the labrum in the hip holds the femur in place by deepening that articulation and making a better fit for that femur on that pelvis. Okay, so this is further reinforced by the strongest ligaments in the body. Okay, and those ligaments of the hip are going to hold that head of that femur in that acetabulum. Okay, so these ligaments are oriented in a way where they surround the entirety of that femoral head, and they're going to create a very strong, very dense joint capsule. Other areas that you should be at least aware of, include that pubic symphysis, which is the front of that pelvis, where the right and left pubis articulate with one another. And then in the back of the hips, we have the posterior sacroiliac ligament, and that holds the sacrum to the ilium on that posterior aspect of that pelvis. So again, there is a lot of the same musculature involved in the hip, groin, thigh, and pelvis that we had at the knee, because these muscles again cross multiple joints. The hamstrings and quadriceps make a return here and return to action, with the hamstrings creating hip extension and the quadriceps creating hip flexion. We also have deeper musculature at the hip that is going to produce hip flexion and extension, internal and external rotation of the hip, and adduction and abduction of the hip. The reason that we are starting with the foot and toes is because, as you should already be aware, the entire body is connected. And since there are very few activities that do not involve ambulation or weight bearing on the feet or walking, being mobile, it is extremely important to know how to prevent injury to the foot and toes to allow the rest of the body to hopefully stay in balance and equilibrium and to diminish the chances of injury elsewhere in the body. We need to understand the structures and mechanics of the foot to be able to understand how to do this. If an athlete is someone who has a weak intrinsic musculature in their foot or a weak arch, they have a predisposition to foot injury that can lead to injury elsewhere in the body. If we can recognize this in our athletes, we can ensure that they are using proper footwear or an orthotic to help support their foot and maintain its correct positioning during a physical activity. We can also recognize that these individuals may need to avoid certain types of terrain, like hard surfaces or even hills, to help minimize the impact on their feet to prevent injury or at least prevent further injury. Now there's a little dance that you have to kind of do as well. We want to avoid extremely hard surfaces without proper footwear, like concrete or roads, but we can also move too far in the opposite direction and have an athlete running on sand or some extremely yielding surface, extremely giving surface that can ultimately cause overstress of the joints and overstress the arches of the foot. These surfaces can also lead to fatigue in the foot musculature, and that can cause or lead to injury in that athlete. The last thing that I'd like to mention here are certain skin issues that we might see. If you've ever gone on a long run or worked out extremely hard for a long period of time, you've probably had a blister in your life. This is caused by improperly fitted footwear, either too loose or too tight, and that friction that rubs on that skin becomes injured, causes that skin to become injured and creates a blister. Calluses are another common issue. These are usually not a big worry, and we actually want some sort of callus to form when we are working with athletes, so that they're better protected. Their skin is better protected with those calluses, especially with athletes who run a lot. The problem arises when there is too much callus that forms, and it causes the footwear to become misfitted or causes the foot inside that shoe to sit inappropriately. Okay, ingrown toenails are also a common issue, and so are corns on the feet. One last issue that is very common is athlete's foot, which is a fungus that actually grows inside damp, dark places. So your shoes, perfect place for that fungus to grow. Thankfully, all of these are very preventable with proper fitted footwear. So make sure that your athletes practice proper foot hygiene as well. So that includes properly washing and drying their feet and changing into clean socks daily or between every practice. Okay. Instruct your athletes to place their athletic footwear in a dry place and make sure their shoes are open so that they can breathe and dry out between uses to help avoid their shoes becoming a breeding ground for bacteria and that fungus, and you can allow them to be able to further prevent those common issues and foot injuries. Lower leg and ankle injuries can be prevented to a pretty large degree through ensuring that athlete is properly flexible, especially at the calves and through the Achilles tendon. We can allow for better movement of the ankle and lower leg and increase the amount of force necessary to cause an injury. This all goes along with the strength of the lower leg musculature. The stronger the muscles, the harder it is going to be to injure them. We also need to make sure that we are doing some plyometric training and really working to improve balance in our athletes so that they can adjust to any unexpected forces appropriately to be able to avoid injury. We need to ensure proper footwear, and if an injury has already occurred, we need to make sure that they are using some sort of brace or taping to further protect that ankle. Also, in sports like soccer, we can prevent injury through the use of shin guards. So preventing injuries at the knee is actually pretty hard. All of our forces that we create in either our upper or lower body are transmitted through the knees, so they need to be accustomed to a very large deal of stress. There are a lot of injury prevention programs out there, especially if we're talking about preventing ACL injury. But in my experience, knee injuries are going to happen even if we prepare the athlete to the best of our ability. Now, that is not me saying that injury prevention programs are useless. They are wonderful and they certainly do reduce the risk of injury. Um, but all it takes is one misstep or one blow to the knee that the athlete isn't prepared for an injury to occur. So the best we can do is make sure that our athletes are wearing the footwear that is appropriate for them, that they are physically fit and well conditioned and strengthened, and that they have gone through some sort of plyometric and proprioceptive and balance training. Some places, specifically for football, require that the linemen use prophylactic knee braces to help limit the amount of injuries that occur. And to some degree, that's very beneficial. But essentially, what we're doing in this case is allowing the athlete to rely on that bracing for support rather than training their bodies to support and protect itself. So I sit in the camp where we should always train the body to defend itself first, and if an injury does occur, then begin to utilize some sort of bracing. Prevention of injuries of the thigh, hip, groin, and pelvis is essentially to ensure that our athletes do not end up with secondary injury in other areas of the body. When this area of the body is injured, it's often debilitating and leads to compensation and compensatory injury elsewhere in the athlete. So through proper conditioning and strength training, as well as plyometric, balance, and flexibility training, we can give our athletes the best chance to prevent injury to this area. We need to focus on dynamic exercises that utilize all of the musculature of the area in combination with the back, knees, ankles, and feet to give our athletes the best opportunity for avoiding injury. So flexibility and dynamic strengthening are keys to preventing injury in the thigh, hip, groin, and pelvis. Pump bumps, clinically known as retrocalcaneal bursitis. This injury occurs when the retrocalcaneal bursa, that lies between the calcaneus and the Achilles tendon, becomes chronically irritated and inflamed by constant rubbing or pressure from the heel cup of a shoe, so improperly fitted footwear. This inflammation can become so bad that it causes the bone to grow abnormally and create an excess deposition of bone or bony growth that further exacerbates this injury. The signs of this injury include tenderness, swelling, warmth, and redness that may progress to a palpable, tendy, bony bump on the back of the heel. If you recognize this injury in your athletes, suggest first that they change their shoes to a pair that do not put so much pressure on their heel. If they are unable to change their shoes, I have had many athletes who are not able to afford a new pair of shoes, right? So if they are unable to change their shoes, this can be cared for by placing a donut pad over the tender site. You can also insert a heel lift into the shoe so that the foot is raised and the area of pressure from their shoes is no longer pressing on that bursa. A heel bruise is just that. It's a bruise on the heel, right? So another name for a bruise is a contusion. So contusion on the heel caused by some blunt force or some repetitive force to the heel. Some of these can vary wildly. They can be very mild, while others can hurt so much that the athlete is completely debilitated and can't walk. These are seen quite a lot with sports that have a lot of stop and go action or a lot of jumping, like basketball, gymnastics, or volleyball. Even though the heel uses a fat pad on it, so there's an anatomical fat pad on the heel, sometimes it's just not enough to absorb the forces that lead to heel bruises. So athletes who are prone to bruising and are participating in activities that I've just mentioned should wear padded heel cups to help prevent these injuries. When we have an athlete with a heel bruise, they are often going to complain about pain in the heel and may even have the inability to tolerate the stress of bearing their own body weight. We can use ice to help decrease the pain in this athlete, and also we just want to make sure that they're avoiding walking, so bearing weight, for at least 24 hours. If they're still having pain with walking after 3 days, then they should be referred to a physician, as they might have a fracture or some other serious injury in their heel. So we can again use a donut pad on this heel to help absorb more force at the site of injury, and or a padded heel cup. So plantar fasciitis is a very common injury. I'm sure you guys have heard about it or even experienced it yourself, but it's a very common injury, especially in athletes that do a lot of running or in athletes who are not used to a lot of physical activity and do too much too quickly. This injury causes pain that runs the length of the sole of the foot and can be caused by certain things like leg length discrepancy, inflexibility of the medial longitudinal arch, tight calves, improper footwear, running on too soft of surfaces, or even if a person is changing their stride length while running too often. Whenever I suspect this injury, the first thing I always ask is, does it hurt when you wake up? First step out of bed in the morning. It's a very common sign when you're looking to assess an athlete with this injury, that their first step that they take out of bed is painful. They often have a lot of pain in the morning that lessens as the day goes on, but it'll increase again when they begin physical activity. This is kind of a bear to deal with. It can have symptoms that last between 8 to 12 weeks, so it is kind of difficult to help heal. But when we recognize this injury in an athlete, we should begin performing immediate, vigorous stretching of that plantar fascia and of the calf musculature. They can also roll out the bottom of their foot with a lacrosse ball, baseball. They can just do hand massage on the bottom of their foot, but they need to do something that's going to stretch that plantar fascia tissue out. In severe cases, we should have the athlete be referred to a podiatrist for a night splint, and that's going to gently dorsiflex that foot and stretch the plantar fascia during sleep. We can also look to use a heel cup to help compress that fat pad under that calcaneus and provide a cushion under the area of irritation. There are also some simple taping techniques that we can use to help take some of the stress off of the plantar fascia and promote pain-free ambulation. If the athlete chronically has symptoms of plantar fasciitis, they should first change their footwear to something that is more supportive of their arch, or they should again go see a podiatrist or an orthotist or orthotics for orthotics that'll help support that arch during activity. Although it's not a life-threatening injury, it can definitely have debilitating effects, and if somebody is trying to continue to be athletic and participate in athletic activity, that is going to have detrimental effects on their performance. So if we see this injury, it should be cared for immediately, and we need so that we can allow the athlete to be able to continue to participate in their sport, as well as just feel good while they go about their daily activities of daily living. Other issues with the arches include a fallen metatarsal arch as well as a longitudinal arch strain. So a fallen metatarsal arch is caused by the heads of the fifth and first metatarsal bones bearing slightly more weight than the heads of the second and third and fourth metatarsal bones. This athlete has pain or cramping in the metatarsal region and has point tenderness with signs of inflammation and weakness in the area, and they oftentimes have a callus form in the area of pain. Those with fallen metatarsal arches should have a pad placed in their shoe to elevate the depressed metatarsal heads, usually under the second and third metatarsal heads, and they should begin a daily regimen of strengthening the intrinsic foot musculature to help build that arch back up. Now, longitudinal arch strain is usually caused when an athlete subjects their intrinsic foot musculature on the bottom of their foot to stresses that they aren't used to. It causes a flattening or depression of that longitudinal arch, which is known as pes planus or flat feet. It can be something that occurs suddenly or chronically over time, right? Some people just have a congenital issue of having flat feet, and they typically, those that have congenitally flat feet or congenitally low arches, they typically don't have any symptoms associated with their feet or flat arches. And if that's the case, if someone does not have pain with their arches being flat, don't try to fix it, right? The old rule, if it ain't broke, don't fix it. So as a rule, pain is experienced only when running is attempted and usually appears below the medial malleolus and the posterior tibial tendon, and this is accompanied by swelling and tenderness along the medial aspects of the foot. We oftentimes also see pain associated with the flexor muscles of the big toe as a result of overuse and compensating for the stress of the arch. If we do need to care for someone who is symptomatic from this injury, we should follow the acronym POLICE, so protection, optimal loading, ice or cold application, compression, and elevation. These individuals should work with their athletic trainer to improve the strength of their intrinsic foot musculature and may also benefit from adding arch taping to allow earlier pain-free weight bearing. So now turf toe is an injury that, as an athletic trainer, it's something that I've seen very often in all athletes, and not just athletes that exercise on turf. Okay, so just because it's called turf toe, don't think that it can only occur in those that exercise on turf. Turf toe is a hyperextension injury of the great toe, so of our big toe, either from repetitive or acute trauma. So typically it's going to occur in athletes who practice or play on unyielding turf, but it occurs on all sorts of surfaces. There are commercial products out there that an athlete can wear to help alleviate symptoms of this injury, but in my experience, a turf toe tape job does the trick. In more severe cases, the athlete should not be allowed to participate in lower body physical activity or weight-bearing activity until the symptoms subside, and then they should be rehabbed back to the point where they can push off of their toes to propel them forward. So fractures. Fractures can also occur in the foot, right? There's bones in the foot, so a fracture can occur there. Oftentimes we see fractures in the metatarsals or in the phalanges. Metatarsal fractures can occur chronically from repetitive stresses, or acutely if someone were to be stepped on or a heavy weight is dropped on that foot. For either of these, if a fracture is suspected, the athlete should be given crutches and they should not weight bear until they have been referred to a physician for x-rays so that they can confirm the presence of a fracture. As a rule, fractures typically take about 6 weeks minimum to heal. Okay, so the athlete should be non-weight bearing until otherwise directed by a physician, or they can continue to be weight bearing if they are given a supportive walking boot and there is no pain during ambulation. Morton's neuroma is a interesting one to talk about. So a neuroma is a mass of nerve cells, and a Morton's neuroma is a mass occurring in the common plantar nerve, and most commonly develops between that third and fourth metatarsal head, and that's because that's where the nerve is the thickest. Okay. These neuromas cause sharp intermittent pain that radiates from the distal metatarsals to the tips of the toes. This pain is often alleviated when the athlete is not weight bearing, okay, so when there's not pressure on that neuroma. They may also have other complaints common with nerve injuries, so they may experience burning, numbness, tingling, things like that. And it's also exacerbated when in weight bearing or when hyperextending the toes. So activities like squatting, climbing stairs, or running will exacerbate this injury. This pain can also be increased from wearing shoes that have too narrow of a toe box or a high heel that places the foot in a position that's going to put a lot of pressure on the front of the foot or even on the toes. This is an injury that can usually be treated by changing the footwear that the individual has been wearing, as well as placing a donut pad at the site of the pain to help reduce that pressure on that neuroma. In more severe cases, a corticosteroid injection might be needed, but that has to be done by a physician so that it can help reduce the inflammation and alleviate the pain. Bunions. So a bunion is, again, something that occurs from improper footwear and is a painful deformity of that first metatarsal. Bunionette is the same thing, but on the fifth metatarsal. Okay, so a bunion involves a bony enlargement of the head of the first metatarsal that progresses to the point where the great toe becomes malaligned and moves laterally towards that second toe, sometimes to such an extent that it eventually can overlap that second toe. It's also associated with a depressed or flattened transverse arch, And often the bunion occurs from wearing pointed shoes or shoes that are too narrow, too short, or have high heels. These injuries are painful deformities of the great toe, and there is an associated tenderness, swelling, and enlargement, and there's calcification of that head of the first metatarsal, and improper footwear is going to increase that irritation and pain. Again, get your athlete in the right shoes as your first line of treatment for this injury. If new shoes are not in the picture for the athlete, a felt pad can be used, placed between that first and second toe to help realign the toes to their proper positions. If none of that works, some bunions will need surgery to help correct the deformity. Blisters, they're a result of shear forces acting on that skin, so friction is going to create an accumulation of fluid under the outermost layer of skin. Can be more common in those that have soft feet or those that use lotion frequently on their feet. That being said, if somebody is prone to blistering, they can use skin lubricant to help reduce the amount of friction they experience on their feet during activity. They need to wear a correct shoe size, wear socks that are too tight, that are tight to the foot without any folds or wrinkles to help protect that athlete with sensitive skin, or the athlete that perspires excessively. And shoes should be broken in before using them for extended periods of physical activity. When we get a blister, caring for a blister is extremely important because improper care can result in infection and create greater issue for the individual. The first thing I want to say is blisters should not be popped. Do not pop a blister if you have an athlete that comes to you with one, or if you develop a blister, do not pop the blister. Blisters should be covered with a friction-proof material or some sort of skin lubricant and a Band-Aid. For further protection, they can be covered with a donut pad that surrounds the entire blister. Make sure that the athlete keeps their blister clean and that they do not attempt to open it up. If the pain from the blister is extreme and the blister is greater than 5 millimeters, they can be drained, but that has to be done in a medical setting, so either by an athletic trainer or a physician who's trained to care for it and to also prevent any infection from occurring. Corns, so there's two different types. There's hard corns and there's soft corns, and hard corns are the more serious type of corn that can occur, and they're caused by pressure from improperly fitted shoes again. So the same mechanism that causes calluses. Soft corns are the result of a combination of wearing narrow shoes and excessive foot sweating, so foot perspiration. The soft corn usually forms between the fourth and the fifth toes in a circular area of thickened white macerated skin and appears between and at the base of the toes. And there's oftentimes an associated little black dot in the center of the corn. And they're typically associated with both pain and inflammation and can lead to disability if that inflammation and thickening of that soft tissue becomes, if that progresses far enough. They should be first treated by getting that athlete in proper footwear. And then that foot should be properly cleaned, and they should be taught foot hygiene, and that foot hygiene should be reinforced to that athlete. Soft corn should be kept dry, and soft pads should be used to keep those toes separated. And then hard corn should be soaked daily in a warm, soapy water to help soften that corn. It should then be protected with a felt sponge or some sort of donut pad. And they can also be removed by a physician or an athletic trainer if they are trained to do so. Ingrown toenails, typically these are going to occur on the leading edge side of the toenail. And this is just when the toenail starts curling in and growing back into a person's skin. Usually results in a lot of pain and inflammation, and it also oftentimes leads to infection. Typically they're swollen, hot, aching, red. They can even have an accumulation of pus at the site of injury, especially if there's an infection present. So we just need to make sure that, again, proper footwear is being worn to help prevent this injury, and that the athlete is actually cutting their toenails properly. If an athlete is cutting in a curved path around the toenail, that's cutting it wrong, and that can actually lead to ingrown toenails. So they need to cut a straight line across the toenail rather than curving around the nail. We're going to treat this by removing the nail that has grown into the side of the toe, and then we just are going to clean that out and clean up any signs of infection and apply an antibiotic ointment. For very severe cases, we want to refer this to make sure that there is no deep infection that will require antibiotics to heal. You may also want to make sure that the nail stays sufficiently long after removing the troubling part of the nail so that we don't end up having to do this repetitively for the same person. Lastly, subungual hematomas. So this is just blood accumulated under the nail. It's typically a result of some sort of blunt trauma to the nail, so either getting stepped on or dropping something on your toe is going to disrupt the tissue under the nail bed, or in the nail bed under the nail. The blood is going to accumulate in that confined space in that nail, and that can, if enough blood gets in there, and it's going to cause extreme pain, and it's ultimately going to lead to loss of that toenail. It's pretty easy to recognize. You're going to see a blue, black, purple, or red area under that nail. It can be treated by applying an ice pack to help alleviate the pain and decrease any further bleeding under that nail. But if pain continues to progress, an athletic trainer or physician can use a special tool to burn a hole through the nail and alleviate that pressure from that bleeding. But it's got to be done under sterile conditions so that you don't introduce bacteria into that area that could possibly result in infection. The athlete then needs to ensure that they are keeping that nail clean and dry, and that they're not putting a lot of pressure through that toe that may start the bleeding up again. Regardless of the area of the body that we discuss, we need to discuss the difference between sprains and strains. So a sprain, sprains are where the ligament is damaged, and that has various levels of severity. So grade 1 sprain are when the ligament is stretched beyond its typical capability and causes some pain and discomfort. These grade 1 sprains are usually pretty mild and typically take 1 to 2 or even 3 weeks to recover from completely. But there's typically some pain and discomfort, but there's no instability, and the patient is usually able to still bear their full body weight, but they may walk with a slightly antalgic gait. And antalgic gait just means they have an abnormal walking pattern. There's usually also some slight discomfort to palpation, and they're usually just pretty sore, right? Grade 2 sprains are when there is some slight tearing of the ligament. So beyond just stretching of that ligament, they are a partial tear of the ligament. They're typically very painful. They usually cause a lot of inflammation in the area of the sprain and are usually very point tender to palpation. If the ligament that is damaged is in the lower body, the patient is usually unable to bear weight, or at least unable to fully bear body weight. There's also some degree of instability associated with these sprains. If we allow that patient to continue to use that area that was damaged, that can lead to further injury. So we need to make sure that we are taking any chance for the patient to use this area away from them pretty quickly after that injury occurs. Okay? Grade 3 sprains are complete ruptures of the ligament. These sprains, again, are usually very painful. They create a great deal of inflammation and swelling at the site of injury. And it takes a lot of force to completely rupture a healthy ligament. So if we are talking about the ankle, for example, we typically will see a grade 1 or 2 before we see a grade 3. But those that have had previous sprains to the ligaments in the ankle in the past are more likely to have a more severe grade of ligament sprain. Grade 3 sprains need surgical correction to fix the ligament. It doesn't matter how much time we give that ligament to heal. If it's a grade 3 full rupture of a ligament, it's not going to heal itself, and the patient will not have proper stability in that area ever again without surgical intervention. There are some ligaments, though, that we do not necessarily need, depending on what our levels of activity are, or our goals for physical activity. So I myself actually have a grade 3 sprain of my AC ligament in my shoulder that I never got fixed. So my clavicle actually sits a little high on my shoulder. But for my life, I don't need to get it fixed because it has no effect on my daily life or the physical activities that I do. Now, when we talk about muscles being damaged, so commonly referring to an injury as like pulling a muscle, we're talking about strains with a T. So strains are graded based on their severity in much the same way as ligaments are. We have grade 1, 2, and 3 muscle strains that we'll classify them as. Grade 1 strains, again, is just overstretching of that muscle, just like the ligament. It's just overstretching, and they're usually pretty mild. Grade 2 strains, partial tear of the muscle or the muscle tendon, just like grade 2 sprain is partial tear of the ligament. And then grade 3 strain is that complete rupture of the muscle or complete rupture of that tendon. So when it comes to somebody asking you if your athlete or patient has a quote-unquote bad injury, you can refer them to these grades as your guide on if it's something that you would consider or they would consider a quote-unquote bad injury or not. Ankle sprains are one of, if not the most common sports-related injury across pretty much any sport. The most commonly damaged or injured ligament in the entire body is actually in the ankle. It's the anterior talofibular ligament, and a sprain of that ligament is typically what we refer to as an inversion ankle sprain. This injury occurs when the ankle goes into an inversion movement that's unexpected. This can occur as an isolated inversion movement, but more often involves a plantar flex movement in combination that also damages the other lateral ligaments of the ankle. Because the ATF is the weakest of the 3 lateral ankle ligaments, it's usually the ligament that has the most damage done to it, but there's often involvement of the calcaneofibular ligament and the posterior talofibular ligament. Eversion ankle sprains are relatively more uncommon. As we mentioned in a previous slide, the lateral malleolus extends down beyond that ankle joint, which is going to limit the amount of eversion that the ankle can perform. That, in combination with the strong deltoid ligaments, creates a pretty stable joint in terms of eversion movements. But that being said, these ankle sprains can still occur. And typically, because of the immense force that is needed to move that ankle into far enough of eversion to damage the ligaments, it's usually a worse sprain compared to an inversion mechanism sprain. High ankle sprains are when the anterior and posterior talofibular ligaments are damaged in unison with the distal portion of that interosseous membrane that holds that tibia and fibula together. These are typically the most severe of all the ankle sprains, and they also tend to have a degree of instability associated with them. Most often, these high ankle sprains are the result of a forced hyperdorsiflexion with some sort of external rotation or eversion mechanism of that ankle. The ankle is usually planted, and a person is usually unable to control their body weight as they are moving into dorsiflexion, and then something else is going to hit them so that they also twist or are moved to one side as that ankle remains in that fixed super dorsiflex or hyperdorsiflex position. These sprains are extremely hard to treat, and they can actually take several months to heal from. For inversion, eversion, high ankle sprains, we have to refer to what grade they are to be able to recognize and manage these injuries. For inversion sprains, for grade 1, typically going to remove them from practice or game to functionally test them, see if they can still perform what's necessary of them to continue to participate in that sport. If they can fully bear weight and they pass all your functional tests, they can go back in. Okay, you don't always need to tape them, but if you recognize it as a grade 1 and you tape them up and they can fully do everything functionally, I usually send them back in. If they can't, ice is usually the best way to go, but just make sure that they're still doing range of motion exercises as they start to recover. The thing to know about grade 1 sprains is that if it's the athlete's first time spraining their ankle, it's usually much worse than any subsequent sprain that they have. Okay, one, they don't know what it feels like, and 2, they don't understand how the injury is going to affect the way they're going to play. So they usually have a lot of emotions going on when it's their first injury, and they usually react pretty aggressively to becoming injured. I've had athletes that have had this injury, playing basketball, they had a grade 1 ankle sprain, and they were able to continue playing without any taping. They passed all my functional tests. They kept going. I've also had an athlete in football who was in so much pain that I couldn't even touch his ankle, and he actually wanted to take a ride in the ambulance to go to the hospital. Kind of crazy that he reacted that way, but again, pain is subjective. He'd never been injured before in his life to that point, so I was happy to send him to make sure he got the care that he thought that he needed and actually wanted. Okay. Same can be said for eversion and high ankle sprains. High ankle sprains, we are typically always going to pull that athlete out. It doesn't matter what grade of high ankle sprain. There's again usually some degree of instability, and until we are able to counteract that instability, we really don't want them playing in any sport. When we have somebody who rolls their ankles over and over again, we end up with something called CAI, or chronic ankle instability. And chronic ankle instability is a chronic issue that results from the weakening of the musculature and the ligaments around that ankle joint. So typically these individuals are going to roll their ankles quite frequently because they have such lax ligaments and such weak musculature around those ankles. But also because of all of that, we aren't really going to see much inflammation or outward damage to the ligaments when they roll their ankle again. They're typically not going to be in as much pain, or if they are, it's not going to last as long, and they usually can bounce back pretty quickly. But that being said, we still want to do everything we can to help limit the amount of times that they roll their ankles, either through bracing, taping, or just making sure that we are continuing to perform ankle strengthening exercises as well as proprioceptive and balance exercises to help them gain control back over those ankles and limit the amount of times that they roll their ankle. This is something straight from your textbooks, but I think it does a great job of giving a guide for how to care for an ankle sprain and what care should take place immediately after an ankle sprain has occurred. So before we dive too deep, I just want to say that tendinitis and tendinosis are two different things. Tendinopathy is another term that you might see or hear. Tendinopathy is just a catch-all term for all of these different terms all into one. So tendinitis is the inflammation of a tendon. It's active inflammation of a tendon, and this is the precursor to tendinosis. Tendinosis is the degeneration of a tendon, so the actual slow death of a tendon or the muscle tissues in the tendon. Tendinitis and tendinosis are both common problems in athletes, but we want to make sure that we identify it as tendinitis and make sure that we prevent it from becoming tendinosis. Tendinosis is the really bad issue where we start to see muscle rupture. So we want to make sure we recognize any sort of swelling, tenderness. There's this thing called crepitus that when you push your finger, when you palpate a muscle or a tendon, you can feel some actually like crunchy bumpiness underneath your fingers when you're pushing into that muscle, and that is also a sign of tendinitis. So we want to make sure we can identify things like that. Use ice cup massage, rest, and also making sure that we again are looking at the athlete's footwear, looking at that athlete's mechanics, making sure that we can do anything we can do to correct anything in order to reverse the effects of tendinitis so that it doesn't become tendinosis. Other things we can use, we can do different modalities, so ultrasound, we can do stim to help with muscle contraction, and then we can also do NSAIDs, so non-steroidal anti-inflammatory drugs. We can also use those to help control the inflammation and the pain. But more often than not, we just have to allow that athlete to rest and make sure that they are taking the time to actually rest so that it doesn't develop into something more serious that could lead to some sort of muscular rupture. So it's important that we are able to differentiate between an ankle sprain and an ankle fracture. An ankle fracture does not always present with deformity and can sometimes be hard to actually identify. In the next slide, we're going to go over something called the ankle Ottawa rules, and that's going to be there to help you make better decisions on if the individual should be referred for an X-ray for a suspected ankle fracture. Typically with these injuries, we are going to see a lot of the same signs and symptoms that are associated with ankle sprains, so pain, inflammation, possible discoloration, inability to bear weight. But there may also be some increased point tenderness over the bone, specifically at the medial and or lateral malleolus, or even the base of the fifth metatarsal. More severe ankle fractures, you will have a visible deformity and the patient will not be able to move their foot very well at all without any pain occurring. These injuries are an immediate referral to the emergency department. And they may be mild enough where the patient will only need to be casted and placed on crutches, or they may need complete surgical intervention to realign the fractured tibia or fibula or any other associated bones of that ankle. When a person is confirmed of having an ankle fracture, they will need to be removed from participant for a minimum of those 6 weeks, again, because that's how long it takes that bone to heal, before they are allowed to start working back into physical activity. So their actual total time to return to athletic competition probably is going to be anywhere from that 8 to 12 weeks or more, depending on how severe that ankle fracture is and what type of fracture has occurred. The ankle Ottawa rules are a set of guidelines for determining if the athlete should be referred for x-rays to rule out an ankle fracture. These have been studied quite extensively. There's a lot of great evidence on them, and they're a great way to help you understand if an athlete is going to be able to be taped up and return to activity, or if they should be sent to the emergency department for x-rays because of a possible ankle fracture. I've attached a link to this lecture as well as added the same link to your D2L, our D2L page for you to look at, so you can further familiarize yourselves with these rules. But there's 5 components to the ankle Ottawa rules. Bony tenderness along the distal 6 centimeters of the posterior edge of the fibula or tibia, so the tip of the lateral malleolus or the tip of the medial malleolus. Tenderness over the base of the fifth metatarsal or at the navicular. And then an inability to bear weight both immediately after the injury and for 4 steps during their initial evaluation. So they can't take 4 complete steps with their injured leg without having to stop. That is another sign or another component of the ankle Ottawa rules. We're going to refer the athlete for x-rays if they have any pain in that malleolar zone that you can see in that picture there, and they also have any one of the listed areas of bony tenderness or an inability to bear weight for 4 complete steps. This is something that often goes unused, even though it has substantial amount of evidence and that it actually works. So I would highly recommend you getting very familiar with this and using it in your daily lives and in your professional lives. So medial tibial stress syndrome, also referred to as MTSS, but more commonly referred to as shin splints. The term shin splints is something that I really don't like. It's kind of a garbage can catch-all term, and it can actually mean many different things. So I like to use the acronym MTSS just because it's just more accurate. So MTSS is an injury that typically affects that lower third of that medial tibia, usually brought on by repetitive stress. It can be some impact, direct impact to that tibia, but usually it's repetitive trauma, either to that tibia or through running. So repetitive impact to the foot and ankle, especially if the athlete's not used to it. So it also can be a consequence of overtraining. But essentially what happens is that posterior tibialis, usually it's the posterior tibialis anyways. The posterior tibialis essentially pulls too hard on the tibia and stays under stress for too long, or it's under stress too frequently, and that causes a site of pain and inflammation at the attachment site of that muscle on the tibia. This is again usually the consequence of running, on training that the athlete isn't used to, a consequence of overtraining, or a consequence, again, of improper footwear. You can see in that image where the medial shin is highlighted. That's typically where the athlete will report pain. Initially, that area is only painful during and immediately after activity, but as that condition worsens, aching pain can last throughout the day. May also start to develop pain in the evenings and in the mornings when they wake up. This is best handled by just resting that athlete or modifying their activity to non-weight bearing. Okay, so maybe if they're a runner, you can have them ride a bike instead, or you can have them run and do a pool workout instead of a land workout. But anything you can do to help unload the weight on that leg and give that area a rest. We can also recommend that the athlete perform ice cup massage on that injury site. It's another great thing. I think that we as professionals in athletics and sports medicine need to start looking at this as a more serious injury. Very often in my career, I've just seen or I've heard athletes say something like, "Oh, I just have shin splints. Yeah, it hurts, but it's no big deal," right? Like, that's sometimes the case. Sure, it's not a big deal, but there's so many times where I've seen this progress into a stress fracture. Okay, so especially if we start hearing our athletes talk about how that pain isn't going away and it's actually waking them up in the middle of the night. It hurts when they go to sleep. It wakes them up. That's a sign of a stress fracture. Okay, so they've actually gone beyond medial tibial stress syndrome and have developed a tibial stress fracture. So this is something that is completely preventable, where we won't have to have the athletes be removed for 6 weeks of their athletic season because they developed a stress fracture, right? We can see it as MTSS and give them the rest they need. I would rather as an athlete, I would rather sit out for 2 weeks of rest with MTSS than have to sit out 8 weeks, right? 6 weeks of healing that stress fracture and then 2 more weeks of trying to get back into action. So it starts with you guys. Just be able to recognize this injury. Be more cognizant that it's not just shin splints, quote unquote. Recognize it as a precursor to a more serious injury that's going to take that athlete out of their sport for multiple weeks if they do not get the care that they need. So as we discussed earlier, the lower leg is organized into compartments. When there is an increased amount of pressure within one of the 4 compartments of the leg, the lower leg, it causes compression of the muscular, neurological, and the vascular structures within that compartment. More often than not, the anterior and the deep posterior compartments are the areas that are most likely to develop compartment syndrome, but they all have a chance to develop compartment syndrome. There's several different types of compartment syndrome, so it's important to be able to recognize each one because there's a slightly different way of caring for them. There's definitely a different amount of urgency to each type of compartment syndrome. Acute compartment syndrome is the worst one. Okay, so this is a medical emergency. This needs to get recognized and referred to a physician immediately. Okay, so this is going to occur secondary to some sort of direct trauma to that area. So being kicked in that anterior aspect of the lower leg, for example. But with this injury, there's a possibility of compression of the arterial and nerve supply, which can result in additional injury to the structures in that compartment, including tissue death and even paralysis. So this needs to be recognized and referred immediately. Acute exertional compartment syndrome is much less common than acute compartment syndrome. It's going to result in an increased amount of pressure within the closed fascial space without the event of some sort of trauma. This type of compartment syndrome typically is going to occur in higher level athletes, but it can also occur in athletes of any level that just after extremely strenuous exercise. Chronic compartment syndrome is 100% athletic or activity related. There's no traumatic event associated with this type of compartment syndrome, but the person that has chronic compartment syndrome typically is going to have their symptoms show up after the same amount of time spent doing an activity. So if you have chronic compartment syndrome and you're a soccer player, you are probably going to start feeling the same amount of pain in the same area at minute 30 of every game you play, right? So that's one thing about chronic compartment syndrome that helps you to recognize it. And then also when you stop the activity, the symptoms also stop. In the event of any of these types of compartment syndrome, the athlete is most likely going to complain of a deep aching pain within their leg. They're often going to feel like they have a very deep cramp in their leg and that they feel extremely tight, so tight that it's to the point where it's painful. They may also develop some sort of paresthesia or decreased sensitivity to that lower leg when compared to that unaffected side. So again, make sure that you are checking everything bilaterally and comparing it to that healthy side to make sure that they're comparing equally. You're also going to see when you compare bilaterally decreases in strength. Visually, there's not a whole lot that we can see because the damage is all really internal with compartment syndrome, but there may be some swelling that you can actually see. But in my experience, when I've seen this injury, it's actually really honestly just looked like nothing. They've just explained that they have had a lot of pain. If the vascular system is affected, though, the leg may appear lighter in color. So check that capillary refill by taking off their socks and then squeezing their toes and seeing if the color returns to their toe after you let go of that squeeze of their toe. If you have identified this injury in an individual, apply ice and elevate that leg above the heart to help decrease the inflammation. But do not, for all that is good, do not apply a compression wrap to this injury. Applying a compression wrap to compartment syndrome will only increase that intercompartment pressure, and that's going to exacerbate the symptoms and actually increase the severity of the syndrome. So do not apply a compression wrap to a compartment syndrome. But with those that have to actually have emergency surgery to release that pressure in the compartment, as you can see in that picture up on the right, they'll not be allowed to return to full activity for a minimum of 2 to 4 months. Okay, if they don't need to have surgical intervention, they should be able to return, but it's going to still take about a month or two. And the symptoms have to be completely subsided. Mobility, flexibility, and strength all have to be returned to normal and equal to the opposite side, and they have to be able to do a progression of exercises and participate in full practices without any symptoms returning. In any case, this is a serious injury. It has to be treated like one. It's not something that we can ever rush back from. Okay, no matter how much the athlete begs, pleads, we cannot rush them back from this. It needs to be treated as a very serious injury, and we need to make sure that their injury is completely healed before we return them to athletic activity. All right, now we are getting up to the knee. Well, so we'll start by going through all of the ligament injuries. We'll start with the MCL. MCL, all of the ligaments, actually, MCL, ACL, PCL, and LCL are all going to be graded like we talked about earlier, grade 1, 2, and 3. But when we start with the MCL here, this is on the inside of the knee, and it's going to help prevent valgus forces, so forces that impact the outside of the knee and cause that inside of the knee to open up. So injury to the MCL often occurs when the foot is planted and a force hits the outside of the knee, which is going to cause that ligament to stretch. There may be some additional rotation to the knee as well that can lead to MCL injury. As we talked about before, grade 1, 2, and 3. Grade 1 and 2 are typically managed conservatively, and grade 3 is going to need surgical intervention to fix. If we recognize this as an injury, we want to wrap it up with a compressive wrap, apply ice, elevate it, and then we want to make sure that the athlete isn't walking on it, so there's no weight bearing on that injured leg. And then we are going to schedule an appointment with a physician so that they can get an MRI to determine the full extent of their injury. The LCL is just the opposite of the MCL. So that lateral collateral ligament protects the outside of the knee from varus forces. So if a force hits the inside of the knee, that LCL is going to be what helps protect the knee. Much less commonly injured ligament throughout all of sports, honestly. I've really only seen this ligament be damaged in sports like wrestling and gymnastics, where there's a chance of very high impact or a chance of landing on something that is going to cause the knee to bow in, like gymnastics. So care for this injury will be the exact same as the MCL: ice, rest, compression, elevation, and then following up with a physician for imaging. We're going to talk about the big boy, the ACL, one I'm sure that you've all heard about. So the anterior cruciate ligament. This ligament is almost always injured through non-contact mechanisms. When an athlete is going to plant and twist their leg, that's actually the mechanism that we most often hear or we see, a plant and twist, and that causes the ACL to be under an immense amount of force. And also when we have a planted and twisted knee, bent, planted and twisted knee, that's actually where that ACL is also at its weakest point. So that's why we have this mechanism of injury so often for the ACL. In my experience, this is typically what I call an all or nothing ligament, which means that you're either going to be fine, so like a minor grade 1 if it's injured, or it's going to be a complete rupture, so grade 3 sprain of this ligament. So I think in my career I've only seen one ACL injury that was actually a grade 2, but it was still surgically reconstructed. It was treated as a grade 3. So when it comes to injury of the ACL, there's really no messing around. Typically, you're going to see that complete rupture if it is damaged. If we're working with patients who want to continue with athletics, they will need to get their ACL reconstructed. It is possible to continue to play sports without an ACL, but it opens the individual up for increased damage and the development of arthritis in their knee, because that knee joint is just now going to move around a lot more without that ACL there to do its job. Furthermore, we are probably you will see this more likely to occur in women. Women are more susceptible to ACL injury than men. They have just wider hips, which is going to change the angle of their femur where it connects to the tibia to form that knee joint, and that's just going to place more force on that ACL. So women are at a disadvantage because they have wider hips typically, and that just puts more force on that ACL. These usually will swell up pretty immediately. At least within that first hour to 2 hours, they're going to swell up pretty good, peaking and swelling after about 48 hours. And the athlete's going to be probably unable to walk without any sort of assistance. They're probably going to be unable to walk. If they are able to walk, though, they're going to probably describe a feeling of instability, or when they step onto that leg, they may feel like their knee is shifting forward. They also are almost always are going to describe some sort of popping sensation that occurred when the injury occurred. Okay, and this is true for MCL and LCL injuries, as well as when we get to PCL injuries in the next slide. Typically, they're going to say that they felt a pop sensation. But again, this is something that we want to ice right away, wrap up with compression wrap, and then elevate, and then take their body weight off of it, use crutches, and then have them follow up with a physician to absolutely confirm the diagnosis of an ACL sprain. And then either talk about conservative treatment if they don't plan on returning to sports, or if they want to return to athletic activity, then talk with a surgeon on planning and scheduling a surgery. PCL strains are not extremely common, but they should be recognized when they occur. Typically, they're going to be from an athlete hyperflexing their knee with some sort of rotation. These ligaments should be treated the same as with any of the other ligaments: compression, ice, rest, and referral. Okay. Unlike the ACL, if we have a high-level athlete that does rupture their PCL, they can still typically do pretty well without any sort of surgical intervention. So these don't always need to get fixed. It used to be the standard, honestly, that if the PCL was ruptured, that the patient would do just conservative treatment without surgery. But we now know that the PCL plays a little bit more of an important role in the knee stability than we used to think. especially in stability and proprioception. So it's a discussion that the athlete just needs to have with their surgeon to decide what's best for them. Lastly, with this, one of the more severe ones we need to talk about is the meniscus and damage to the meniscus. So damage to the meniscus often comes in the very same way as an ACL injury, right? So a plant and a twist. That's going to cause excessive compression and rotational force on that meniscus, and that's going to create a tear in the meniscus. These will also cause the knee to swell up pretty immediately. When it comes to the amount of pain that results from these injuries, I've had athletes in the past who have been completely unable to walk because it was so painful. But I've also had an athlete who was able to walk right around without any sort of issue at all. I had an athlete complete an entire game of basketball without coming off the court, and they were playing on a torn meniscus. So the most common finding, though, is that you're going to see that inflammation start to occur, that effusion start to develop in that knee. They're also very commonly going to talk about feeling like there's something inside their knee that's stopping them from fully extending their knee, or it's also could be stopping them from fully flexing their knee. They also usually talk about some sort of clicking or a catching feeling in their knee when they're walking or when they're moving their leg. If the meniscus injury is suspected, we need to refer to a physician, again, to get that absolute diagnosis through an MRI that is ordered by a doctor. Depending on the size of the tear of the meniscus, we can either do a debridement or a meniscectomy, and that's usually a pretty quick, very easy, quick procedure. Typically, the individual is able to return to full activity actually within 2 to 4 weeks. So the surgeon just goes in, cleans up the small pieces of meniscus, and sends the athlete back on their merry little way. But there is a very high chance that the athlete will develop osteoarthritis as they continue to get older. The other option, if it's a bigger tear, the surgeon will do a meniscal repair. Significantly more invasive, requires a much longer recovery period. But typically, the individuals with a meniscus repair will be out from full participation until about 4 to 6 months after their operation. However long it takes to get that operation scheduled, could be anywhere from 4 months to 8 or 12 months, depending on how long it took them to have that surgery after they had their initial injury. So something that is not in your book, but I wanted to mention, is the unhappy triad knee injury. Okay, so the unhappy triad is 3 different structures. We have the ACL, the MCL, and the medial meniscus. When these are all damaged at the same time, they are known as the unhappy triad. They are often damaged at the same time because they are all damaged with the same mechanism of injury, plant and twist, okay, on a bent knee. If the individual has an unhappy triad injury, that is going to increase their recovery timeline by about a month or 2, compared to if only one of these structures was damaged. So just be able to understand that just because we learned about all of these individually doesn't mean that they can't occur or that they don't usually occur in isolation or in unison. Another injury that wasn't in your book, but it's important to know about, is a tibial plateau fracture. So especially if we're working with individuals who are younger, have softer bones, or if we're talking about athletes who are older and have some sort of osteoporosis, or if we're just dealing with athletes that can land from a very high height, right? So if we're talking about gymnasts, for example, that's who these injuries are going to occur in. If an athlete lands without bending their knees, if they have poor landing mechanics, that force from landing is going to go straight into that tibial plateau and can cause a fracture in that tibial plateau. So you're going to see swelling at the site of injury. You're going to see an individual who's unable to bear weight. A lot of times their range of motion is super affected. They don't want to move their knees at all. But this injury can mimic other injuries of the knee, so it's super important that we refer for X-rays to rule out the presence of a fracture in the tibial plateau if we suspect it at all. Because if gone untreated or unrecognized, it can lead to severe deterioration of the knee, especially at the knee joint. It can cause osteoporosis. It can cause even death of the bone. So it's a very serious one that we need to also be aware of. So I always thought that this was kind of a fun one. When an individual has a lot of force that hits their knee, either due to a blow from an object or from hitting the ground really hard on their knee, it can rupture the bursa sac. Palpating a bursa sac, it feels like a water balloon. Okay. When it happens, there is almost immediate swelling. Okay, so that bursa sac bursts, and it is almost instant how fast the swelling comes to. Thankfully, it's really just a bad bruise. Okay, it is painful for the athlete. It does hurt, but it really is it feels just like a bad bruise to the individual who has the bursitis. Thankfully, there's nothing structural that is damaged. The knee is still perfectly fine. It just looks pretty rough. Okay, so if they are actually able to compress that bursa back down, compress that knee, and they can handle the pain, they can usually go back and continue to play. But most often the pain is actually so bad, like it feels like such a bad bruise that they don't want to continue to play, or they can't put much weight on it. Or they don't want to risk it getting hit again because it is so point tender. The one thing that I want to be clear about, though, is this can actually mask other injuries. So just because you know that there's a bursa sac that has been ruptured, you want to make sure that you still are ruling out any other sort of injuries that may exist underneath all of that swelling. One of those injuries that can exist underneath all that swelling is a patellar fracture or a patellar dislocation. When that athlete falls directly on the patella, it might swell up because of that bursitis, but it also may be swollen because of a fractured patella. So we need to make sure we're doing our correct observation and evaluation of the injury and making sure that there's no fracture site located on that patella, especially if we saw that athlete land directly on the patella. Another thing that we need to be aware of is a subluxation or a dislocation of that patella. So subluxation just means that it was partially dislocated, so it either fully left its normal position and returned, or it just partially left its position and then came back. And then a dislocation is where it fully leaves its resting position and remains out of position. Patella dislocations typically are going to occur laterally on the knee, and the athlete is usually found with that knee in a bent position, with that patella sitting out of position. If you are not trained to do so, do not reduce that patella. Okay, don't put the patella back in until somebody who is trained to do so can come and put it back. If you're not trained how to put it back in to place, you can actually cause a secondary fracture. So it may not be fractured when it dislocated, but as you put it back in, it might cause a fracture either on the femur or on the tibia or on the patella itself. So you want to make sure that you're trained to do so before putting it back in. Runner's knee is tightening of the IT band that causes the IT band to snap over the lateral femoral condyle at the knee. This constant snapping causes too much friction where the IT band and the femur meet at that knee, and there's going to be some irritation and inflammation that follows. This is an injury that if it's left untreated, there can be immense pain on that lateral aspect of the knee, especially when the person is running or walking for long periods of time. Typically, this is caused by an issue with muscular tightness at the hip, so efforts to create more hip mobility and flexibility will help alleviate this injury. Ice and massage are also great for this injury as well as resting, but improving that flexibility and mobility is going to be the best bet for helping to improve IT band friction syndrome. Jumper's knee, so patella tendonitis. It's an extremely common condition, especially in jumping sports, so basketball and volleyball. You're going to see a lot of this. You also see a lot of it in youth athletes, as they grow, their tendons basically just can't keep up, and they develop patellar tendonitis, also known as that's more commonly called Ashgood-Slaughters when it's in somebody who's growing. But pain is going to be right at the patellar tendon. If you palpate that patellar tendon, you can have some point tenderness in that athlete, and you're probably going to feel that feeling of crepitus. The pain is usually going to occur in that patient when they jump, when they land, if they're running, and if it progresses far enough, it may even just be when they're walking. And again, if it continues to progress, they may go from having pain only during activity to having pain when they're just sitting down for long periods of time. Okay, so it also gets worse with the duration and intensity of exercise. But massaging that tendon and increasing the flexibility of the quadriceps is one of the best ways to help this injury, not only in prevention but in treatment as well. The coach should also look at the individual's jumping mechanics. If the athlete lands with their knees falling in toward each other, it can cause or exacerbate this injury. And working on jumping mechanics, so jump training and hip and thigh strengthening, will also help to correct this injury and prevent it from becoming worse. So contusions, again, contusions are bruising. Contusions can occur anywhere in the body, but in sports, a lot of time, it's a very high chance of impact to the quads. So in the case of a quad contusion, most often the individual can continue on about their activity without much issue. But with more severe contusions, there can be a debilitating pain, and even just moving the leg will cause a lot of pain and inability to perform an activity. So if we do have individuals who have more severe quad strains or quad contusions, we should apply ice, but we want to make sure that they're icing it in a position where that quad is on a stretch, and we want to have that ice on there for 20 minutes while they're also stretching for 20 minutes. If we allow them to ice and remain in a lengthened position, we can actually increase their chance of developing something called myositis ossificans, which is just basically a hardening of that muscular tissue, myositis ossificans. And that hardening of the tissue also could be called a contracture. And that basically is just that muscle hardening and becomes unable to function properly, and can lead to further injury or even rupture of the muscle tissue. So, as we mentioned before, with any sort of muscle strain, we're going to classify it as a grade 1, 2, or 3. Where grade 1 is that overstretch that muscle tissue without any tearing, or very, very minimal tearing, all the way to a grade 3 where it's a complete rupture of that muscle. These pictures here are both grade 3 strains. The upper left picture is of the hamstrings and the lower right is of the quadriceps. These are often referred to as pulled hamstrings or a pulled quad when it's a grade 1 or 2, but then when they get to this severe, usually they say a grade 3 hamstring or a grade 3 quadriceps strain, or just a ruptured quad or a ruptured hammy. As you can see in both these pictures, there is a depression where the rupture occurred, and then a raised bump where the muscle is actually now currently resting. Right, the muscle is now currently sitting at that bump, and that bump is called a Popeye deformity. Popeye is a cartoon that was created back in the 1920s. You can see him here. He has these crazy-looking forearms, right? His arms are not what you would expect to see in somebody who has got normal musculature. You would see that kind of arm in somebody who's ruptured their muscles, so or their muscle tendons. So hence the Popeye deformity. Now, not every hamstring and quad strain is going to be a grade 3. So in fact, we're very seldom going to have complete ruptures. Most often, we're going to be dealing with those grade 1 or grade 2 strains. And those injuries can be wrapped to help assist their muscular action so that the athlete can still participate in their sport activity, but also still allowing that muscle to heal. So that's kind of a cool thing that we're going to end up learning how to do. But we don't want to have the athletes that have a quad or hamstring strain be stagnant. We don't want them to just be sitting in one spot and doing nothing with those injured muscles. Okay, we want them to be moving and be engaging those muscles to promote healing. Now we can overdo it and and that's going to increase the amount of time that it takes for that muscle to heal. But the best recommendation that we can give is to allow them to do activity that does not cause pain. The activity can be uncomfortable, but pain is never okay. Labral tears are very similar to meniscus injuries in the knee. The patient will typically not have a ton of pain at rest, but they will have quite a bit of discomfort with movement and will most likely also feel a clicking sensation within their hip. Depending on the severity of the labral tear, the individual might be able to work through the injury conservatively, or they may need surgical intervention to correct the labral tear and return to their full athletic ability. Groin strains affect the proximal medial thigh. These individuals can have just some tenderness with specific movements, or they can have an intense amount of pain that inhibits their ability to even bear weight on their affected side. There is usually point tenderness, and there may be associated bruising depending on the grade of muscle strain. Rest, ice, and rehab to strengthen the musculature is necessary for healing, as well as improvement in biomechanics, flexibility, and mobility to prevent any further injury or repetitive injury. I'm not going to go super into detail because a strain of the hip flexor is going to be almost exactly the same as a groin strain. Only the pain will be more anterior rather than medial on that proximal thigh. It may also even refer some pain up into that abdomen. We will handle this in the same way that we would do for the groin strain. So ice, rehab, strengthen, stretch, and correct mechanics. Iliac crest contusions or hip pointers are another contusion that occurs in sports. We'll want to protect this area with some sort of foam padding before allowing these individuals to return to athletic activity, especially in sports where there's a high risk for another impact to the same site. So especially in sports like hockey and football or even lacrosse, even soccer, we would want to make sure that we are really making sure that this is protected with some sort of foam padding so that the contusion is able to recover. Ice cup massage is also a great way to help treat and heal this injury, but like with other contusions, the best medicine is time and moving as normally as possible to allow this to heal. So this is a video of one of my former athletes. On her dismount, she lands pretty awkwardly. I just want you to think about what we've gone over throughout this lecture, and I want you to think about what you would do if you were at this event and you saw this occur with one of your athletes. What do you think happened? What would you immediately do? What would you want to make sure you do when you follow up with your athlete?